Hi, good afternoon, everyone. I'm Oliver Gao. I'm the director of the Cornell Systems Engineering Program. We've been having this Ezra Systems Speaker Series for quite many years, and it's really an opportunity to put together people in different fields, but with interest and also with the focus of topics across different disciplinary areas. So today we are very delighted to have one of our own. Actually, we have Professor Yiye Zhang down from New York City. She's actually assistant professor in the Division of Health Informatics. And also she is the program director of the master's program in health informatics, and also course director for continuing medical education at the Department of Population Health Science down in the city with Weill Cornell Medicine at Cornell University. So if you look at her experience, she actually has a very nice what I call systems engineering experience, covering all these different topics from information technology all the way to health. So especially she's having this experience in developing the tools to analyze and visualize the healthcare information, including the EHR, electronic health record data. As a principal investigator, her research has been funded by multiple federal agencies. So I'll be brief, and actually Dr. Zhang, she received her PhD in information systems and management at CMU. And then she has a BA in mathematics from Washington University in St. Louis. And in between, and she got her master's degree in biostatistics from Columbia University. So Yiye, it's great to have you. Now the floor is yours.
Thank you so much, Oliver, for the introduction. It's a great pleasure to be able to present today at the Ezra Roundtable Seminar Series. So today's topic is studying the association of maternal mental health and the built environment using health informatics. And here are my disclosures and conflicts of interest. And please feel free to unmute yourself during the talk to ask me any clarifying questions. I'm happy to have a more interactive talk for the next hour. The talk today is about the built environment, which I know is a topic that's near and dear to the heart, probably to many in the audience. So the built environment is the human-made environment and landscape that surrounds us, such as the buildings, the houses, the parks, and the highways, the roads that really help shape who we are as human beings. So the built environment significantly influences the way we commute, particularly during the pre-COVID days when we were always out and about to carry daily living activities, entertain, exercise, lead a healthy lifestyle, and so on. So from a health perspective, since everything we do does go back to our health, we can also say that built environment significantly affects our health, and in fact is considered to be among one of the 5 most important social determinants of health. So I have a diagram of the social determinants of health in the slide here, and you can see that, of course, the most important one is healthcare, where we receive our primary, our emergency, our outpatient care, but we also consider the economic stability, social and community context, education, as well as neighborhood and environment to significantly affect our health throughout the years. So the association of the built environment and health has been quite well studied in previous literature, but I do want to point out a few notable papers that I think are worth highlighting in today's talk. So notably this year, COVID-19 has been our mind, unfortunately. And researchers actually early on has pointed out, this is a group at Columbia University, they have pointed out that the COVID-19 transmission among a pregnant woman in New York City, this is among the Washington Heights community that is in the Upper West Harlem area. And researchers had found that COVID-19 transmission was associated with the built environment. This was published in JAMA, one of the most prestigious medical journals, where it was pointed out that household membership, household crowding, and low socioeconomic status are some of the neighborhood and environmental factors that were associated with COVID-19 transmission. And in fact, COVID-19 or all of these respiratory illnesses are highly impacted by the built environment because of the infectious disease dynamics, particularly in disease transmitted by contact, aerosols, or droplets. So there was also a recent study that came out, very recent in Science Advances, where the researchers at Johns Hopkins had looked at a large-scale data of 3,000 counties in the US, where they also had COVID-19 mortality rates, and they found that even a slight spike in air quality in the PM 2.5 could be associated with an 11% increase in a country's COVID-19 death toll. So just a few very timely examples of how the built environment is associated with really our daily health as we speak. And now to more of a topic that's related to today's talk, it's also been well documented and well studied that poor quality environment can affect not just our physical, but also mental health. So for example, Galeo et al. Had pointed out back in 2005 that poor quality built environment, for example, noise level or the lack of proper city order can affect mental health across populations. And built environment, while not as well studied as health in general, but healthcare use has also been pointed out to be associated with built environment. And anecdotally, we can all sort of think that it makes sense, as in how easy we are to the hospital, to the urgent care, to the emergency care can definitely affect whether we are going to or not going to get the care that we need. So this is also a new study that came out in 2020 in the Chicago Community Adult Health Study, where researchers pointed out that the women's use of preventive care were associated with odors and noise level in the neighborhood. So these are some examples of how previous literature had looked at the health and the built environment. And a lot of these previous literature were drawn by conducting long-term cohort studies where researchers followed a certain population for 2 years or 4 years in interviews, in surveys, or randomized clinical trials. One thing that's different in the talk that I want to focus today is the way that we analyzed the association of health and the built environment, which is through the electronic health records. So I don't know if many are familiar with electronic health records, but it's the computer system that when we go to see the doctor, that the doctor use. It's a software the doctor use to document patients' health. So you might have seen the doctors talking to the patients and turning back to the computer to document patients' demographics, labs, vitals, health conditions, as well as any prescription medication information and imaging reports. And doctors would also write free notes in the electronic health record system, as, for example, discharge summary, follow-up summaries, and so on. So this is a system that's been adopted for more than a decade, and thanks to the Affordable Care Act and the HITECH Act has been really widespread currently in the U.S. hospitals. So as you can imagine, this is a wealth of health data that's routinely collected every minute as we speak, as patients go in and out of the hospital, as they're getting treated, their information are documented. and stored in the electronic health records, which we researchers can use for different purposes. And for myself, actually, the first time I got to know electronic health records data was through a internship that I did. This is a long time ago at a pharmaceutical company, where the job given to me was to understand how pharmaceutical companies can use electronic health records to understand how doctors are using medications as an off-label, so that the pharma company can investigate in innovative marketing strategies. So electronic health records is not just used for hospital operations, but it's also used by researchers, by pharmaceutical companies, by insurance companies, and lately large tech companies such as Google has also been publishing papers, very high profile papers, for example, in Nature and so on, where they are collaborating with academic medical centers to use electronic health records to predict patient outcomes. So, so this is the data source that I will be talking today in going through our 2 studies on looking at maternal mental health and the built environment. And I also have a diagram here, which is a little hard to see. Apologize for the small font, but I wanted to give you more context of the data, the health data and its structures, so we can better orient ourselves as I talk about the different variables that that we extract from the electronic health records. So this is called the OMAP Common Data Model, and this is a very highly commonly adopted data model for electronic health records. So we use it at Cornell, and it's also being used across the country in the US as well as internationally in China, in Korea, and in Europe as well. So as you can see here, in the database, we'll have patients. So this person table corresponds to the patient's demographics information. And we also have all of these separate tables that captures, for example, mortality information, the encounters, how many times and how often one person comes to see their doctors, what are some of the procedures that they have received, what are the medications, devices, health conditions, medical history, lab measurements, and it also contains the clinician's free notes, free text notes as well. So it has both the structured and unstructured fields, where the unstructured fields contain more nuanced information, and we can apply natural language processing and so on to better understand. This is often where patients' family information or any sort of these non-clinical information that clinicians may use to document will be in the notes section. So I wanted to point that out as a pointer as we go through the talk. So for this talk that I'm going to go over, the electronic health records and the data all come from Weill Cornell Medicine. So Weill Cornell Medicine is part of, we are a part of Cornell University. We're part of Weill Cornell Graduate School of Medical Sciences, and also part of Weill Cornell Medical College. Along with Cornell Tech, we're located in New York City. In particular, we're in the Upper East Side of Manhattan, and we're affiliated with New York Presbyterian Hospital, which is the largest health system, 10 campus health system that serves the New York population. So, so as you can imagine, our data set naturally draws from this urban environment, from this urban population. But as I will show you in the next slide, we also have patients, because of the healthcare quality and the renowned clinicians that are part of Weill Cornell Medicine and New York Presbyterian. We also have patients coming from different states. So we have not just New York, but we also have New Jersey, Connecticut, Pennsylvania, and from other parts of the country, such as California, Florida, as well. So this is, so I just wanted to give you a sense of the scale of the data that we're looking at. And this is not the latest statistics. I wasn't able to get the most latest, but this is the data that we had at the when we were processing our data for the analysis, where the number of patients in our database was 1.5 million. We had over 1,800 different kinds of condition classes, 486 drug classes, just to show the complexity of the clinical conditions that are in this database, and 51 million encounters as in visits to the emergency room, to the hospital itself, the inpatient setting, and the outpatient setting. So Weill Cornell Medicine has many of the outpatient clinics, and we also have data from the emergency room and the inpatient side from New York Presbyterian Hospital. So this is, again, a very, very large data set that we were able to work with. And I think one variable that may be of interest to this group is the fact that we also had patients' home location. So this is actually in joint work with Drs. Mohammed Tayarani and Dr. Gao here, and we were also working with our Weill Cornell Medicine's research informatics team, but we were able to geocode patients' home location that was documented in the electronic health record. So this is where they say when patients fill in their information, this is the address that they filled, self-filled home location information. And we were able to get the longitude and the latitude and map it to different 11-digit census tracts to different parts of New York City, which then later on allowed us to link the electronic health records clinical information with the publicly available built environment information. And I'll go into more of the details on geocoding and the kind of built environment data that we were able to receive. I just wanted to also mention that as part of the introduction. So, so given that, given this long introduction that I had in setting up the stage for why we're interested in the built environment and health and the study setting and the novelty of conducting these community health or population health studies, not with actual patient follow-ups or interviewing, but with this routinely collected detailed data set that is electronic health records at an academic medical center in New York. I want to give you an outline of today's talk, which can be separated in two parts. So the topic, the health topic that I'm going to focus on is postpartum depression. And I want to give you an overview of how we use machine learning applied to electronic health records data to understand what are some of the predictors in the electronic health records of this significant serious postpartum depression, this condition. And taking the predictors that we learned, that we capture from the electronic health records, I then want to tell you how we were able to map or reconstruct a trajectories of health events during the women's 9-month of pregnancy period and understand what are some of the built environment factors that may be associated with the way that the pregnancy care might have gone in the 9-month period and how that may lead to different kinds of maternal mental health outcomes. So with that outline, I want to then jump into the first part of the talk, which is understanding the predictors for postpartum depression. And please feel free to unmute, or I don't know if I'm not able to see the chat. So if you have any questions, oh, there is a question. I assume the electronic health records you mentioned have the patient's identity protected. Yes. So everything that we do is approved by our Weill Cornell's internal review board, and we're under HIPAA regulations. So we're not dealing with any patient health information that's identifiable. Everything is everything that you see in this talk will be fully de-identified. Hope that clarifies the question. And again, I'm not able to see the chat, so feel free to just unmute and stop me if you have any questions. Okay. So a little bit of background about the postpartum depression, this condition. So I think that when the society talks about pregnancy and newborn baby, I think we typically associate newborn baby pregnancy with very joyful, rosy images. We see terms bundle of joy, celebration of new life, and of course it's one of the most exciting milestone of a person and the family. So typically, I don't know if anyone's done this, but I've actually been to Barnes and Noble and went to the newborn section, the pregnancy section, and I was curious to see actually, is there any book in particular that prepares women or prepares the family on the tremendous potential changes that may happen to the physical and the mental health during the pregnancy and the 1 year after child delivery. And so when I went, I actually only saw sort of one book that talks about this this very difficult part of pregnancy that we don't like to bring up. However, it is postpartum depression or peripartum depression, maternal mental health. This is a real condition that is very complex and actually has been estimated to affect as many as 1 in 7 women. So this is surprisingly and very unfortunately a common condition that we typically in society do not want to talk about. The postpartum depression doesn't just affect the moms; it also, as we can imagine, it affects the babies, it affects the dads, and the whole family. So the economic cost and of untreated postpartum depression has been estimated to be as high as 14 billion annually. So this is not just a complex health condition, but it also has significant societal impact. And the importance of postpartum depression prevention has been emphasized by WHO, by the American College of OBGYN, and the US Preventative Services Task Force as a very important task. And there's recommendation that women should be screened for this condition during pregnancy. The challenge, however, is that this is a condition that is that tends to be hidden. As I mentioned, we don't want to maybe think about the potential depression while we're going through this supposedly happy period of life. So many women choose not to disclose, and so as a result, there's still a knowledge gap on what exactly are the risk factors, what exactly are the predictors of postpartum depression. So based on the current literature, we know that mental health history, active mental health conditions are one of the major predictors, as well as domestic violence, lack of familial support, poor income and poor education level, and biochemical, immunological, and endocrinological risk factors. All of these are known risk factors. However, there's a lack of primary prevention. And most of the current approaches are focused on the secondary prevention, which is to screen for women as opposed to preemptively try to identify women who may be at a higher risk of developing this mental health condition. So currently, the approaches is that the women must have the symptoms already the symptoms of depression or anxiety already, then they will be given these depression questionnaires where they can answer. Some of the common ones are Edinburgh Postnatal Depression Scale, Predictive Index for Postpartum Depression, and so on. But currently there's a lack of methods or tools that can identify women before they show symptoms of depression. So that really motivated us because we had interest in mental health and we had this large data sets of multi-years of patient records, and we had a tool that we thought were promising, which is machine learning. So this really motivated us to start thinking about the possibility of, can we leverage machine learning and electronic health records to develop a model that can accurately and preemptively identify expectant mothers who may be at a higher risk, so that they can be referred to appropriate psychiatric interventions, therapies, and so on to prevent this serious condition from occurring. And so this is the patient population or the data sets that we used in trying to start this process. So this one actually, so this study, actually, we were fortunate to have two data sources. One comes from Weill Cornell Medicine from 2015 to 2018, where we had 17,000 expectant mothers' records during their pregnancy, that 9 months of pregnancy, as well as 12 months after. So one of the exclusion criteria for our work was that we excluded women who didn't have any encounter records with us within 1 year after childbirth, so that we can accurately make sure that if they did develop postpartum depression, or if they did had any health conditions, they were treated as Weill Cornell, which will be captured in our data as opposed to other health systems. And we also excluded women whose age is above 45 or under 18. And we developed a model here at Weill Cornell Medicine, but we were fortunate to have a validation data set, which came from the New York City Clinical Data Research Network, which included 7 academic medical centers. So this includes Cornell, Columbia, NYU, Montefiore, Mount Sinai, Albert Einstein, 7 large academic health systems combined, which gave us a validation data set of 53,000 patients who we then later on tested the machine learning model that we trained at Cornell. And in this data set, the main chunk of the data came from electronic health records. And the records, as I mentioned, was represented using the OMAP common data model. All of our diagnoses were represented as the SNOMED codes. This is one of the terminologies that's used internationally to represent diagnosis. And all of our medication and dosage information were also standardized by anatomical therapeutic chemical classification system. And we did all of this so that our model can be transportable potentially if we wanted to other health sites. And the outcome was defined using the SNOMED codes for postpartum depression in collaboration with our clinical collaborators in psychiatry and OBGYN. And we also defined postpartum depression as someone who had taken antidepressant within 1 year after delivery. now skip through these details and the specific codes, but if you have any questions, I'm happy to answer afterwards as well. So our variables mainly were categorized in these buckets. So we had demographics information such as age, race, ethnicity, and we had the medical condition as in diagnoses, their corresponding codes, and the type of diagnosis, whether it was medical history or it was active diagnosis. We had medications, as I mentioned, in ATC codes, and we also had everyone's lab measurements as well as vitals, body weight, blood pressure, and so on throughout the pregnancy period. So every time a patient comes in to the clinic, if any labs were drawn, if any vitals were drawn, that will be accumulated and we will be able to use it in our analysis. So we had this longitudinal records for our patients during the 9 months period. And we also collected the encounter information, as in how many times they've come to see the doctor, if they had visited the emergency department, and the visit to the emergency department during pregnancy is considered to be an indicator of sometimes an indicator for the lack of a proper access to primary and OBGYN care. So we also wanted to collect ED visit times. And then lastly, as I mentioned, clinicians do have these free notes. So we applied a regular expression search in the notes to also get the patient's marital status from the data. So these basically summarize the variables that we used in training the machine learning model. And in terms of the methods, we used sequential forward selection. This method we applied on top of the commonly used machine learning models, and this is really to make sure that we're choosing only the most predictive variables, as opposed to building a large variable with a couple hundred variables, and that is an important consideration if anyone is interested in developing these models in the healthcare setting, because we always have to think about the implementation. So typically, if we're interested in developing a model that we want clinicians to use at point of care, then this model needs to sit on top of the electronic health records, meaning that we have to engineer, work with our electronic health records vendors or our internal technical team to make sure that the model is getting the appropriate variables in a timely manner, so that as the doctors are seeing the patient, our model can output these risk prediction outputs. So as you can imagine, we don't want a model that is very expensive, very slow to train. We're looking at a simple, interpretable. Interpretability is very important because we always have to explain to the clinicians why we think one patient is a higher risk or lower risk. So we're looking at, we're aiming to always build small and yet predictive models. And so that's why we were trying to use this sequential forward selection, which allowed us to sort of just get the minimum sets of variables that had satisfactory predictive power. And so this is the modeling framework that we used. So here is our EHR data sitting in a relational database represented in OMAP common data model, where we were extracting these variables. And then we'll go through the eligibility criteria and and split the data into training and test sets. So in our case, we did all of our training and also internal testing at Cornell. And as I mentioned, we also used 100% of the data from New York City Clinical Research Data Network, which was the 7 academic medical center, as an independent validation set. So we applied the sequential forward selection on top of these off-the-shelf machine learning models. And every iteration that we had a model that we were ready to, that we thought were ready, that we thought had a good predictive performance, we met with our clinical collaborators to ask them if the variables made any sense. And we did that because our model basically drew from everything that was inputted into the electronic health records. So sometimes we had variables that were trivial. For example, for some reason, pregnancy's second trimester, this term for some reason was included in one of the iteration as the predictors, which clearly is just to indicate that this patient is had gone through the second trimester. So these sort of not clinically meaningful, these trivial features we were able to prune out by meeting with our clinical collaborators who helped us get to a final model that not only had satisfactory model performance, but made enough clinical sense. And I'll be going through the predictors in a few slides. So I can now begin to show some of the data and the patient profiles that we collected through this study. So as I mentioned, we had data from our own Weill Cornell medicine, and we also had data from the 7 academic medical center, which represents a more broad patient characteristics, patient population, and also different kinds of neighborhoods. So in Cornell, if you remember, I mentioned that Weill Cornell medicine is in the Upper East Side of Manhattan. So the patient population that we cater to are slightly different from some of the other academic medical centers that are located, for example, in Bronx or in the Lower East Side of Manhattan. So we did have some different patient characteristics in terms of age. Our patient on average had a higher age than the patients from the CDRN data, and our patient also had a much lower number of emergency visits during their pregnancy. And we also have their race information as well, which were also slightly different as expected. So this is the model performance that was applied on the data sets, on the 2 data sets, and we tested our data. We tested our model at different times of pregnancy. Here I'm showing the results at 24-week and at 30 weeks, where we were able to get an AUC of 0.95, sensitivity of 0.84, specificity 0.96. So we were glad to see that our models were predictive. That's important, and more importantly, we were interested to see what are the predictors that are predicting this postpartum depression. So apologies for the small fonts, but these are the predictors and how they associate with each other in our model. This is a 33 feature model, which we actually, our co-authors and I and our clinical team are currently working to implement Weill Cornell's OBGYN clinic. But we were glad to see that the predictors that we identified are consistent with the expected clinical predictors from previous literature. So for example, mental health history, as we all know, is is a significant factor for postpartum depression. And we also identify some complications or disorders during the pregnancy, as well as the use of certain medications, such as beta blockers and antihistamines, and the different kinds of delivery mode, such as C-section, and encounters during pregnancies were all of our predictors. So we were happy to get these 33 features that we were somewhat comfortable that were making clinical sense. And so the next question for us as a research team was that now that we have these predictors and we know they appear during the pregnancy, we wanted to understand, does the built environment associate with these predictors? And if so, how did they associate with it? So our sort of a bigger question was, if we know that a woman may be at a higher risk of postpartum depression, does that probability, is that affected by where the woman lives? And if so, is it because of the built environment's impact or the built environment's association with the patient itself? Or is it because of the way the built environment affects or associate with how a woman gets the pregnancy care? So that's the question that we next were interested in conducting. And the way that we tried to answer this question was through clinical pathway learning. So clinical pathway learning is in a way a process mining approach, where for us, we took all of the predictors, the 33 predictors, and we map it to each individual's timeline during this 9 months. And so for us, we had every woman's timeline of when did each event happen during the 9 months. And we were trying to identify similar patterns, where the similar patient clusters, where the predictors happen at the same time or in the same combination, which we hypothesized would give us different or separate subgroups among the whole pregnancy population that we're looking at. And we further hypothesized that if we can get these underlying subgroups of patient clusters, then we can test if the built environment factors are associated with whether a person is more likely to be in one cluster over the other. And so we applied further clustering algorithms, and we also tested our hypothesis using structural equation modeling, whose results I will show in a few slides. But just to recap what I said, this is how we were trying to map everyone's timeline during the pregnancy period. So we were trying to see if, for example, subject 1 or subject 2 is more similar to each other. And if so, we were trying to find similar clusters just based on the sequence and based on the types of events that they experience during this period. And then the built environment factors that we were trying to assess if they were associated with the cluster memberships that we were trying to get were coming from these five categories. And again, this is joint work with Drs. Tarayani and Dr. Gao. We looked at first accessibility to resources. So some examples here were on the distance to the nearest bus stops, subway stations, parks, and bike facilities. And we looked at the traffic volume, heavy or light traffic volumes within 250, 500 meters of the patient's home location. and we looked at how the neighborhood land use was looking like. So Dr. Tayarani gave us the land use mix index, the floor area ratio for different purposes, including retail, residential, commercial, facility, and so on. And we also had a sense of the street connectivity, as in the number of intersections, so that we can get a sense of the homogeneity or the heterogeneity of the neighborhood. And we had air quality information from PM 2.5 and nitrogen dioxide. And we also wanted to control for some of the social factors that we know must be associated with health. So these are poverty rates, Gini index, average percentage of college degrees, median home values, and so on. And so the way that our data files were structured, in case you're wondering, is that for each patient, we would have the home location, and our Weill Cornell research informatics team would geocode these home location into 11-digit FIPS codes. Then we would pass these to Dr. Tarani and Dr. Gao to do these geospatial analysis and to compute the variable values. So again, for this second part of the analysis, because we had to limit to patients whose home locations were reliably available, so our population size was down to 8,900, but it's still a very good number over a 3-year period. And this is some of the demographics information that we had access to. For example, age, BMI, we had the gestation week at the time of delivery. We had race, we had marital status, the delivery mode, and we also had the patient's insurance types, whether it's commercial, Medicaid, or other. And something that I want to mention is the race information. Recently, increasingly, race has become a very important variables to understand. And so in the electronic health records, we do have race information. However, we also face the challenge of patients not writing the race accurately, or sometimes if the clinics gets very busy, we don't always have time for the nurses or for the clinicians to track the patient and enter their race information. So we do have a pretty high rate of unknown race. So that's something, if you're interested in electronic health records, that is a limitation that we have, and I wanted to point out. And these are the populations of built environment factors that we were able to collect. Number of bus stops, subway stations, park areas, bike path length, the vehicle kilometers traveled for light vehicles, for heavy vehicles, and the land use indicators, air quality, as well as some of the social characteristics of the environment. Please let me know if you have any questions. And here are the 3 clusters that we were able to identify by applying clustering algorithms to the clinical pathways that we constructed for the patient population. So the 3 clusters, we were actually we thought it was interesting in that, so we through the clustering algorithm, this data set, we didn't give it any indicator that we were interested in postpartum depression. So it's a fully unsupervised algorithms, and we were sort of curious to see that the clusters were quite different in terms of the rates of postpartum depression. So this cluster 1 here of nearly 2,000 patients, had 6.7% of postpartum depression. And the second group of 4,000 patients had roughly half of the rate, it's 2.66. And then the third cluster had half of the rate compared to the second cluster of 1.14. So we thought it was interesting that the cluster sort of separated meaningfully in terms of postpartum depression. And we were also interested to see some of the clinical characteristics. For example, this group with the highest postpartum depression had the lowest rate for normal deliveries. So likely these group probably had some delivery complications or went through C-section, which, as you can see here, that the pregnancy complication rate of this group is much higher than the third cluster with the lowest postpartum depression rate. It also has high-risk pregnancy. Elderly primigravida means that the patient age is above 35. So we also have mothers with higher age in this group. And if we look at the abnormal glucose level, this group is also higher, much higher compared to this group, which seems to be the healthy population group. And so that was very interested to see. And we were also interested to see what are some of the built environment factors that are associated with the relative likelihood of a person being in the high risk cluster, which is this cluster 1 compared to cluster 3. And we also looked at what are the built environment factors and what are the coefficients that makes a person relatively more likely have a higher odds to be cluster 2, which is the moderately risk group in terms of postpartum depression, as opposed to the low risk group. And so we did this in the structural equation model where just by looking at the rates, the odds ratio compared in relative to the low risk group, the cluster 1 has 6.3, cluster 2 at 2.43. And perhaps of most interest are the environmental factors that we were able to find, which includes the retail floor area ratio, PM 2.5 for air quality, the land use index, as well as the Gini index and average college degree of the neighborhood. So that was an interesting finding, and I know that I have just 5 more minutes, so I just wanted to very quickly summarize the finding from the first machine learning piece. Is that we're among the first in predicting postpartum depression, and even though we had some missing data from the EHR, we're still quite happy with how the model performed, and the future work for us is to link the maternal information with their newborns information, so that we can continue to study the association or any predictive capability of our model predicting any further child outcomes. And from the second study, the finding that we saw from the models were that retail floor area, the land use, air quality, and the land and the neighborhood's education level, income equality, or some of the factors that determined or that were found to be associated with the different cluster memberships. So I wanted to sort of anecdotally talk about this, and I'm also interested in the audience feedback as well. Is that anecdotally or from the built environment literature and from what I hear and learn from Dr. Teherani and Dr. Gao is that retail floor areas is indicative of the walkability of the neighborhood, and the mixed land use and the more retail access could be a proxy for how much the neighborhood is connected and how much community support it offers to the women. And so this is something that I was talking, this is something that that the OBGYN collaborator was telling me, is that she can totally see if a pregnant woman has more places to walk to, this allows her to stay more active. And if and if there are more community support, if she can go into a store and talk to others, then it's more likely that perhaps there's more emotional support that the new mom is able to get from the neighborhood. So the findings, the results so far need to be validated, but we're seeing some potential indication for a community having more social contact, more support to be associated with a lower risk of maternal mental health issues, which I thought is really interesting, and something that I'm very passionate to study further in the next phase of our research studies. So I am just 4 minutes until the end of the talk. So I just wanted to quickly conclude that in the two studies that I talked about, we were able to demonstrate machine learning models to identify postpartum depression predictors. And we also found some association with built environment and community factors in this urban setting. And I wanted to acknowledge the co-authors who provided their technical and clinical input to the work. And I also want to acknowledge the funders for the study, which is the Center for Transportation, Environment, and Community Health, Walsh McDermott Scholarship, NIH, and the China Scholarship Council. So with that, I have just 3 minutes, and I want to see if anyone has any questions.
Yeah, that's great. And actually, usually, when we have the, in-person seminar, sometimes our seminar could, last to about like 1:30. So people, if you have time and you have questions, please feel free to raise and stay with us. But people, if you need to leave, please feel free to leave. But yeah, anyway, questions. Let's see if anyone.
So I have one question that it may sound random, and it probably is, but when I've been associated with Hong Kong and to a certain extent other parts of southern China, I noticed that the buildings, tall high-rise buildings, always have the several floors of shops in them, so that each particular building, without having to walk very far, you can still get on the elevator and go to these shops. But they have this high retail to residential, whatever you call it, percentage of retail space there. And I was wondering if there's any, indication cross-culturally whether this postpartum depression is different than in typical U.S. cities. You have, especially modern ones in Russian cities or something, like they build buildings up and then the shops are nowhere nearby. You have tall skyscrapers, pretty much all residential in some areas, and they don't have any. They don't no nearby or interlaced retail space. Right.
No, that's a good point. So I do think that perhaps New York City, given the work was done in a New York City very urban population, we're likely also looking at neighborhood with high-rise buildings, and it's potentially these shops are part of the maybe on the first floor of a residential buildings where we have large department stores with in a high-rise building. So I unfortunately have not looked at the postpartum depression or the maternal mental health in a different population. But just in terms of the landscape, and I feel like probably Dr. Gao and others know more about this than I do, but I feel like in terms of the urban environment, I'd be curious to see if similar findings can be found in a different urban cities.
Thank you.
So, yeah, if not, yeah, I have a very quick question. So, we're doing this research. Of course, I think we're trying to be very rigorous in the methodology and looking into the data and trying to make sure that the model is getting rigorous results for us. But have you thought about if we discover all these relationships, this association, have you thought about the implications of such a study and how can we possibly disseminate the result to influence the policy making and even the urban development, especially now I think post-pandemic, people are now going to think very seriously about urban settings. So I think maybe such study can come out timely to provide some important implications for future urban development and city planning.
Right. Yeah, no. So in the first study where we were able to validate our findings at least 7 different academic medical centers, that really boosted our confidence in our finding. Whereas I think for the second part, we have findings from one health system, one city, but as we were just saying, that we actually don't know if it will generalize to other urban cities or what about the rural areas. So I think it's really important for me to identify potentially partners at other areas in the country or internationally, where we can apply the same approach and see if we have the same findings. So I'd be very interested to see if there are any clinical research network that I can collaborate with.
That's great. Seems like I think let's so yeah, this is really great. So it's really such a nice topic. I think kind of across different disciplines, right? From the built environment all the way to the health outcomes, from physical health to mental health. This is really great, and we want to thank you again and have a nice weekend.
Thank you so much for having me. Thank you for the questions. Have a great weekend, everyone.
Thank you. Bye-bye.
Okay, bye.